Welcome to an afternoon of entertainment on KROX 1260 AM and 105.7 FM and online, broadcasting live from the Christian Brothers Ford Studios.
And as we do every Thursday from 2:30 to 3 o'clock, we're talking all things medicine with Dr. Fennell, and we have a return guest, Dr. Abbasi, joining us once again, and it sounds like we've got a couple new subjects to be touching on, and a pretty big honor that shows just the quality of work you're doing in a couple weeks as well coming up.
Exactly. So thanks for having us back. It's a nice fall afternoon. It looks like we're finally getting some of the harvest completed. These poor farmers getting beat up with all the water out there. Heavens to Murgatroyd, I wouldn't want to have their job right now. Today we have Dr. Abbasi coming in from his home down in Alex, and he's up here today working with us in Crookston. Dr. Abbasi is a neurosurgeon, and he has been, I think, probably one of the most innovative neurosurgeons I've ever met as far as how he's been taking the problems that we've been dealing with in lower back and chest and spine issues and coming up with whole new techniques of solving these problems. We're going to start today with an old Bugs Bunny problem. It's our aching sacroiliac. How many people have said they've got that problem? They think they got sciatica or some issue like that. So, Dr. Abbasi, welcome back.
Oh, thank you very much. It's always a pleasure.
So, we're going to focus to begin with on this issue of the lower part of our pelvis, and it's this pain that we call the sacroiliac joint and the things that can go wrong in that area. So, first, give us a description of what kind of discomforts people have, how it affects them, and then we'll talk about how we figure it out, and then we're going to talk about how we treat it.
Well, sacroiliac joint by definition is where our sacrum, or the bottom part of our spine, joins our pelvis, and there are lots of critical structures in that area, including our lower lumbar spine, our pelvis, our hip. So traditionally it has been really hard to diagnose the problem of this area, but generally people have lower back pain. As a matter of fact, about 1/4 of the time when people have problem in the lower back, that's actually attributable to the sacroiliac joint and not the spine itself.
So what makes this a little bit different for those who kind of wonder where we're talking about is the most common problems are right in the midline in the lower back, right in the center of our back. But the sacroiliac joints, there's two of them, one for the right and one for the left side, and they're a little bit off center from that lower down in the butt.
Yes.
And what makes it confusing is that all of the pains in the midline of the back can shoot down to those areas. So they can seem to be the same issue and can be very hard to distinguish them sometimes.
Yeah.
But today we're starting talking about when this joint, which is the lower part of where the lowest part of the spine connects to the pelvis, and that's the sacrum, it connects to the ilium, which is what we call the sacroiliac joint. And it's a fairly broad area, 5-6 inches long.
Yes.
And it actually is mobile. There's a little bit of mobility takes place in this, and women know all about that. When they get pregnant, then those ligaments get loose, and the whole pelvis is designed to open up a little bit.
Yes.
So it's that zone that we're talking about. So
Yes, now sacroiliac joint is a sort of oddball in our body. We call it a joint. It's not really a joint in the sense of that enable us to provide any usable motion. As a matter of fact, there's not a single muscle that act on the sacroiliac joint alone. There are muscles that go over it, but not a single muscle that makes it move. As a matter of fact, we believe that if it moves, it's actually when it gives us the problem. And the way we know that is we know that the sacroiliac problem are 4 to 7 times higher when women give birth in the first year after delivery. And many of my patients, they tell they can actually point to it. They put their finger on it. That is, doctor, where my pain is, especially in the night when they turn from side to side. That can give them significant amount of pain. And as well, they report that, especially when they do activities, obviously when we are upright and put pressure on it, that the activity, the pain gets worse. And I think it's important to know that for a very long time, we doctors neglected the sacroiliac joint for a simple reason. The solution we had for it was worse than the disease. As a matter of fact, that has been described, sacroiliac disease has been described in 1920s and 30s, before spine problem has been treated surgically. But once we could treat the lower back, we sort of neglected the sacroiliac joint because the surgery that would require to fix that for a long time has been going there, destabilizing, it, literally destroying all those ligaments. It was used to be that people lose a good part of a gallon of blood in that kind of surgery. So until just about 10 to 15 years ago, we neglected sacroiliac joint, and we stopped doing all research on that because we didn't have a good solution for that. In the last 10 years, lots of things has changed.
Well, let's go back to the beginning. What would somebody do that would make their sacroiliac joint become a problem? Is this just something that happens in an individual through life, through their activities? Are there more specific injuries that take place? Or are all the women who are childbearing destined to have this issue?
The usual patient with a sacroiliac joint is actually younger. I mean, younger in the sense of younger than a lumbar spine or the lower back problem. They are in their sometimes even 30s, 40s, and 50s, and they, as we talked about, female just after giving birth, they have higher rate, as well as obviously any kind of sport, especially impact sport, can contribute to any kind of joint problem, including sacroiliac joint problem.
So, what kind of symptoms do they bring to your office and say, Doc, I've got a problem in my back, and what would make it so that you would think that this is more likely the sacroiliac joint rather than their lumbar or lower back problem?
No, it is based on the pain alone. It's extremely difficult to distinguish between the sacroiliac joint and the lumbar spine problem because, like in our fingers, we have such a density of nerves that we can distinguish if it's something is a fraction of an inch to the right or left. But internally in our pelvis, the nerves that give innervation to the sacroiliac joint, they are practically the same that giving innervation to our lower lumbar spine. So pain alone cannot make that distinction. But generally, it's a pain. It's a high-grade pain that gets worse with activities. And the pain that is not exactly center, maybe a little off center, as well as the pain that especially I hear that very often, that in the night when people turn from side to side or twist their back, gets significantly worse. As a matter of fact, many of my patients, they tell me it wakes me up in the night.
Now, is this something that you say twist, your back hurts? Is this something that a chiropractor can treat?
Well, I think chiropractors do a great job with muscular kind of pain by adjusting those muscles and bringing balance and deep tissue massage and reflex therapy. If the problem is the joint itself, an organic problem, meaning that there's a problem, bone is grinding the bone, I think that already has moved beyond the reach of physical therapy or chiropractic management.
Okay, all right.
But you never know. When patient come to you, you never know, is it there or not? So we always try conservative therapy first.
Okay. All right, so we've got this person's come in, they've got this lower back pain. We're kind of suspicious that it involves this thing called the sacroiliac joint. What steps we do go through next to try to diagnose that so we can be a little more certain about it?
Well, like many other area of the body, and on the orthopedic side, Dr. Fennell, you are yourself an expert on that. If we have a question about if that area is causing the pain, we have so-called provocation tests. We put more stress on that area to see if we can, by provoking it in a controlled situation gently, if the pain gets worse. Once that result, that exam is done and the result is favorable toward the sacroiliac disease, we have another kind of diagnostic. We call it diagnostic sacroiliac injection, where we put a certain amount of novocaine or bupivacaine, same thing that the dentist put in your gum before he starts drilling your teeth. We put it in that location and we tell the patient, go do things that are usually painful and come back and tell us. If we get repeated improvement, and the diagnostic criteria in the United States is meanwhile at least 2 positive injection, each of them 75% improvement, even for a single day, then we know that that is where the pain is coming from. Now, as everybody knows, when you go to your dentist, that numbing medication lasts 4 to 6 hours because our entire mouth is well perfused with blood and the medication wash out faster. But in the sacroiliac joint, it is not as well perfused, so that injection can last actually up to a few days. Now, the way we do that, we have improved on that. We choose, this is not an easy injection. This is not an injection that every random person can do that, because this is not a real joint. This is not enough space to go in, but there is a protocol. We have improved on that. When we go in, we put certain amount of the local anesthetic with steroid. And I have had a good number of the patients that after my 3 so-called diagnostic injection, the pain got better. And there was no need for me to do anything more. So we have improved that we make our diagnostic injection as well diagnostic and therapeutic injection. But if the patient come back after 3 injections in our hand and the pain is still coming back, but we had the positive effect of the bupivacaine or the numbing medication, then we know it's beyond the reach of conservative management. Then we have fantastic surgical options just in the last few years for this problem.
So back it up a step. So to begin with, you talked about this provocative examination test. So in other words, we poke the bear when we're in the office.
Yes.
We try to do things that are going to exacerbate or make this pain more obvious, and hopefully that helps to isolate it. And if that's the case,
No
then
pain, no gain.
no pain, no gain. And then the next step up is we do this injection. Now, is there anything special about how the injection done? Is it done in the office? Is it done in the radiology department? Or how do we specifically make sure we're getting it in exactly the right location?
Yes. Again, if anybody looks at the sacroiliac joint, notice initially that this is unlike any other joint in our body. It bends and twists in so many different ways, and I don't believe there's any single joint in our body that is so diverse that it looks from one person to another, even in one person look different on one side versus another. So it is a big deal to do it right. And you need lots of experience with that, as well as you need to document it well. How was the pain before and after? What could you do before and after? And so we have put all those protocols in place. Certainly, we use an X-ray machine. And with the X-ray machine, we make sure that the needle is in the right place, which is the lower part of the disc, which we call it articular region of the disc. And then we have as well set up a good protocol that it puts certain amount of medication. We put some contrast in to make sure that it's not in a random place. So it is a science for itself. But if it's done right, it's extremely powerful to identify the problem, and then it opens significant amount of options for the patient.
Okay. All right, so we've taken all this effort to try and sort out this patient, figured out we've injected them, stuck some steroids in them, and they got better for a while, but it didn't last, or it lasted maybe a short period of time. Now you tell me that there's some brand new options for surgery. This is getting kind of exciting because this has changed. Like you said, the first go around, we used to do these big operations, patients will lose a huge amount of blood, and now we've got something much more delicate. What are we doing?
Well, let me first tell you what we used to do, because it makes sense to understand that just by a simple change of concept, how much improvement we can bring to patients' life. We used to go from the middle point, from the mid-back, go to the side where the sacroiliac joints are, and we have to take lots of ligament, lots of tissue, lots of blood vessel out to reach the joint itself. And as a matter of fact, it was to a point that we would do it only in combination with other surgeries if they're needed, because that was maximum and maximally invasive kind of surgery. And as you described, those numbers are realistic. Lots of blood loss, hours and hours of surgery, months and if not years of recovery time. In the last I would say probably in the last 20 years, we understood the anatomy enough, and we could have instrumentation and technology that enable us go from the side to inside, from the outside of the joint, from the outside to inside. We call this lateral approach, but means that we go from the outside, and our incision is barely bigger than 1 inch, that enable us to put 2 very specialized screws across the joint. Just in the last 8 years, we made this 5-hour surgery to a 1-hour surgery, and our technology now enable us to do that surgery even within half an hour. And there are good indication, and we are working with different groups on that to make that even a 15-minute procedure. This horrible surgery is now a day surgery.
So we've gone from something that patients, you only did it when it was an absolute desperation in combination with something else because it was such a devastating operation. Now we're talking about a 15-minute, go home the same day operation through a 1-inch incision.
Well, yet still half an hour's procedure, but the technology is improving every year, and this is truly has been a miracle of, at least in the area I'm working, has been a miracle of medicine that I have been observing in my lifetime.
How common is it? We're talking about like it happens all the time. Is this a pretty common problem out there?
Now, this is one of those like a field of dream. If you build it, they will come. If you look at it, it's everywhere. If you are not familiar with it, you never see it. And that's a problem because we couldn't fix it. We neglected the diagnostic of it. That has become almost the orphan child of musculoskeletal problem. But if you look at it, and we have done those studies, almost every fourth or 23% of the lower back problem are sacroiliac joint. If you had a surgery in your lower back, that rate doubles, meaning that almost every second or every third of the problem after you had the spine surgery is going to be sacroiliac problem, as well as there was something we never understood. Many of these patients, they have leg pain, and we never understood why should anybody with a sacroiliac joint have leg pain. But now we understand all those major nerves, we call them lumbar plexus or lumbosacral plexus, they go over the sacroiliac joint. If the joint is inflamed, irritated, all those nerves can be irritated. So we understand now that it's a part of the problem that you have leg pain if your problem is in your sacroiliac joint.
So the great masquerader of the lower back is the sacroiliac joint. We've been neglecting it. Now it's coming much more to the forefront, and you're right at the very beginning of a group of people that are now doing a very slick, minimally invasive type of operation to solve the problem. And results so far, from what I've been hearing, have been quite spectacular.
The result has been better than spinal surgery on the lumbar spine or disc and so on by far. This is one of those things that people are going with pain for years and years, and they come, we do the diagnostic. Nobody really looked into the sacroiliac joint. We do the diagnostic, and then we do it 4 weeks later. They come back and say, "Doctor, my life has changed. It is a different world for me now."
So for all those people out there who've had back pain for a long time, sometimes they've been told that their lower back isn't necessarily the cause of the problem, but nobody's really come up with a good answer for them. And there may be, hiding out in the weeds, an answer for them of where this discomfort's coming from. Well, we're going to move the topics to something a little more, I think maybe more near and dear to your heart than this last one. The whole concept of minimally invasive lower back surgery and how that's evolving as we speak. I had you here about 6 months ago talking about this. What we're talking about, for those who are hearing this for the first time, is traditionally in low back surgery, we were doing fairly large open operations for problems with arthritis, for problems with where the space in the spinal canal wasn't big enough, for problems of curvature of the lower back that were for degeneration. And traditionally, we made giant incisions and pulled all the muscles apart, and then we put screws and plates and things in there to try to get things lined up right. But the consequences of all of that invasion that we were doing was fairly substantial. And you've been in the forefront of this technology of doing this now through small incisions, very delicate little operations, done multiple different locations in the back, but allowing us to accomplish exactly the same operation, but much more quickly and with a higher degree of reliability as far as getting things to heal. So I'll let you just kind of give a summary of what is taking place these days and what's new that you've seen in the last year.
Well, just in the last 6 months, we had another paper published, our landmark paper based on 300. We have done thousands of these surgeries now. And practically what we are solidifying this result. The result is undeniable. We have a new sheriff in town. We have a new way of treating this. And the old ways, even though some people are still clinging to them and don't want to let them go, it's extremely more damaging than with this new technology. I just did this surgery 3 times just around the corner in Crookston. 2 of them are already of the patient are discharged, and the 3rd one I'm going to go back after this interview and discharge home. This is unheard of, and even in the major centers, we get now constantly patients from major centers that they are told you need a stage surgery, 2-day surgery, 1.5 year recovery, and they come to us, we look at them, and we are able to do that surgery in 1.5 hours and send them home next day. As well, we hear a lot of, unfortunately, that is almost unhuman, that when people are older and if they have other disease, the surgical open old-fashioned will become exponentially more dangerous. They are told, go live with it. It is hard to be old, but it's much harder to be old and in pain. And those people who had no hope, now we are able to give them hope by providing a surgery that doesn't require 8-hour surgery or a gallon of blood loss, but 1-hour surgery and an ounce of blood loss that is much more tolerable. Now we are able to provide and widen the number of the people that they can benefit from this kind of surgery.
So
and that happens in your corner every day, and you are taking care of them. Your team in the Crookston is taking care of them. The other day I heard from good doctors in the Riverview that since we are doing this surgery, the post-operative complication has gone down 75%. That is unheard of in medicine, that one change makes so much impact in patient care.
So we've had you said you had some 3 people. We're talking surgery was done Wednesday, and this is Thursday afternoon.
Yes.
And of those 3, 2 are home already, and one's going home shortly.
I'm going to go and discharge the patient.
Yeah, and these are, I can say from experience, these are operations that in most other hospitals in this state today, these patients wouldn't be going home for 4 or 5 days, and they'd be looking at about a year length of recovery. And we're expecting, based on these techniques, these patients to be feeling pretty darn good by the early new year, which it's changing the dynamics of lower back surgery in a way that nothing else ever has. And the spectrum of things that you're able to treat with this is becoming increasingly more broad. We started off, I think, with fairly straightforward degenerative arthritis of the lower back, but now there's a few other aspects of it you're taking on as well.
Well, like anything else, we started, or I started it based on certain indication, certain medical condition. But when I saw what the result was, I put a good team together. We call that team Inspired Spine. And that team, with a group of researchers, engineers, people who are interested to bring the care to the next step. And many of those team group are doctors and the caregivers here in Crookston and other places. We have developed this. We have a big center in the city where we have machines that we prototype these new devices and new techniques, new protocols. So we have been successfully widening the range. Now we do scoliosis surgery with this MIS technique. We are one of handful. You can count on one hand number of the places in the whole world that they provide minimal invasive spine surgery for scoliosis. And guess what? We are one of them here in Crookston.
Yeah, you're in Crookston, one of the handful in the entire planet that can do
Yes.
what we're doing here. Yeah, and from a personal perspective, your dedication to getting this information out to the world. I got hijacked last night for 3 hours to go over a research paper so that it was be ready to be submitted for publication on this coming Friday. So you keep pushing the information out to the people. You're not hiding this. You want the world to know that
Yes.
how this can be done. So that's pretty amazing that the amount of effort you put in, not only in the operating room, but in the hours late at night trying to get this information summarized for other people to read about. That's,
The best time is between 10 p.m. and 2 a.m. to do this kind of job. And, I'm very lucky. I have no other hobbies.
All right. Well, we have said we have a very special guest going to be coming to Crookston. We have, rumor has it, that's not just a rumor, it's a fact, the president of the Japanese Spine Society, Dr. Kim, who has interestingly trained at the Mayo Clinic and then spent, I think, 7 years at the Mayo Clinic before going back to Tokyo. And he's now basically running the spine systems in Japan. Well, he has become so intrigued by what's going on in Crookston that Dr. Kim is coming to visit Crookston on December 4th this year, so in about 5 weeks. And he's coming to see how this procedure is done on the lower back. So if there was ever any debate about how amazing this is, when you start having the presidents of world-renowned spine societies coming to Crookston to watch how a new procedure is done, that's really quite a statement. And if I'm correct, I think you're leading the operation that day, is that?
Yes, I have 4 operations that day. Usually in a spine place, doing 2 surgery, that fills a day. And as you know, I did yesterday 5 surgeries because we made the big surgery small surgery. And in that day, we have scheduled 4 surgeries for Dr. Kim Fo to come and have a look at this procedure. But it's more than that. This Saturday, I'm meeting with a group of surgeons in Jordan who are interested to see that. Last week, I met with some surgeons from Germany again who are interested. We are getting international recognition because we have now the results again. And lots of people are still critical. In medicine, critic is a good thing. Being suspicious and being careful is a good thing. But once people with open eyes and open heart look at the data, this is a game changer by any standard of care.
As I've said before, this is kind of when we started introducing camera systems into joints and into abdomens.
Mm-hmm.
We started doing gallbladders instead of through big operations through small incisions. We started taking out cartilage in knees through tiny little incisions. And it's changed dramatically a number of different fields of medicine. And the low back guys really weren't doing so much of anything, weren't even interested in this kind of thing. And now we've got this whole evolution taking place with new technology, but you're backing it up with the outcomes over, like you said, over 1,000 patients been treated this way over the last 5 years. So it really is becoming super legit. And I say it's a testimony that people from Japan don't come to Crookston very often unless there's a good excuse for that. And this, I think, you're proving to the world that this is a good excuse.
In a way, the result is so unbelievable that we have put thousands of patient testimonial out there because it is easy to find one good patient and put one testimonial out. And some of my group, when they ask me, why do you put like again and again and again, we get it, but the idea is the rest of the world is lacking behind us, is far behind us, and we have to convince the rest of the world that this is a game changer. And by us putting these thousands of testimonial the day after the surgery, a month after the surgery, 6 months after the surgery, a year, 2 years after surgery, we can show this is a new kind of treatment that has sustained result over a long period of time. And that is what I think we can show it as well with scientific data, like the paper that you and I reviewed yesterday, to the rest of the world. I can just repeat myself, the results are undeniable.
It's impressive. Just a little aside, a little piece of trivia from your data. The traditional low back surgery has a failure for the whole purpose of the operation. This is typically a fusion that has a failure rate of about 25 to 30%.
Even more.
And you've shown that that's because of all of the tearing apart of the blood supply to the area that we're actually operating on. Your technique eliminates that, and you said we have a 98% fusion rate?
The fusion rate is significantly higher, which has been read by independent radiology in our group. But fusion for us is as well just an indication.
Right.
We have gone contrary to many of our colleagues that they want to reduce a person to numbers. We have gone do it the hard way, meaning that follow up that patient 3 months, 6 months, a year, 2 years, and actually go back to look at the clinical results, and as well by combining these protocols with our clinical outcome. And along the way, not only we check how they are doing, we steer them in the right direction.
Right. But this was just an example of where it shows that it's transforming how these operations are succeeding, and then you see the effect of that, which is the clinical results are in a whole different league than anything we've seen before. So I commend you to keep it up. It's a long road. You still have a lot of skeptics to convince, but you're doing it the right way, and the patients, as you say, their voices are getting louder and louder. They're going to be showing people that this is really a very successful way of helping them.
But always a pleasure to be here.
That is the Medicine Explained program. Our thanks to Dr. Abbasi. Hopefully we'll have him in the future as well. And Dr. Fennell, I hate to put you on the spot, to have an idea of maybe where we're headed next Thursday?
It's Christmas time coming up. We're going to be bringing our dietitian here to talk about how do we avoid that holiday bump.
Well, that'll be, I'm sure, relevant to not just the announcer here, but I'm sure a lot of our listeners as well. We're looking forward to that again next week. It's 3 o'clock.